Hello and welcome to Season 2, Episode 71 of the Physician Assistant Exam Review Podcast. This week, we're going to be covering oropharyngeal infections and inflammatory disorders. I thought I'd mess up oropharyngeal, and I messed up covering. Wow. My name is Brian Wallace. I'm the host and creator here at Physician Assistant Exam Review, and I am so thrilled to be here. I've been having a ball here at Physician Assistant Exam Review and getting tons of feedback and lots of email communication with different members of the community, people who have been passing their exams, people who haven't passed in a couple of tries, who have been able to finally get through it using some of the methods that I discuss. It's been a really good week of that kind of thing going on. So I do encourage all of you to think outside the box a little bit. If you've been struggling on exams, I definitely have some stuff. If you're not on the email list, I cover some there. If you're not in the Scholars newsletter, I cover a lot of that in that particular publication. There's definitely information out there for you. So definitely look into those. And you can get started at physicianassistantexamreview.com. That's the way to go there. Anyhow, it does look like the COVID numbers have been consistently dropping, at least at my hospital, which is exciting news because I thought that after everything sort of opened up around here, they opened the beaches in my area. There's been a lot more people out and about. I certainly had some concerns, but I personally would not have been that concerned unless the numbers doubled or quadrupled, and they've actually gone down a little bit at my particular hospital. Again, that's only one data point out of thousands and thousands of data points, so it doesn't necessarily mean anything, but it is very encouraging. I'm looking forward to things starting up. I just got an email literally 2 minutes ago, and the texts are flying about my younger son's baseball team. They've literally put a tournament on the schedule, I think every single weekend from July 10th through the beginning of September. So I'm not sure, how if you guys are going to hit the ground running in quite that same fashion, but it looks like we're going to be very, very busy from hanging out at the house every weekend, every day to, the vines and trees and bushes taking over everything here again. So, but it should be good. It should be something to really look forward to. Obviously, there are some other issues going on in the country right now. I'm not going to comment on those on this particular show. We talked about the COVID epidemic because it's a healthcare issue, but I'm not going to go into the other issues going on around the country right now. I didn't want to just not mention it at all and blow by it because obviously it's a concern for everyone. His hearts go out to those people who are involved, and so that's as much as I wanted to talk about that here. Let's move on to the reason why you come here, which is to cover medicine in a way and in a style that's a little bit different and in a way that helps you to package everything up and retain it a little bit better, I'd like to think, than most places. So we're going to start off, as always, with our priming questions. Number 1, pseudohyphae on a KOH prep should make you think of what diagnosis? Pseudohyphae on a KOH prep should make you think of what diagnosis? When you hear the term hot potato voice, what diagnosis should you think of? When you hear the term hot potato voice, what diagnosis should you be thinking of? Name the white oral lesion that is easily scraped off but bleeds when removed. Name the white oral lesion that is easily scraped off but bleeds when it's removed. All right. So see if you can pay attention, see if you can grab those out as we move through. They should be pretty obvious, pretty easy. This section is awesome for writing questions. I'm working. It's been a struggle, especially with everybody home all the time, but I'm working on remaking the final step, which I've been working on for some time. It's not coming out anytime soon, but I'm just putting questions together, and there is just a ton of questions in this section that are so easy to write. There's some things I'm going to cover that may or may not be on your exam, but it's just so easy to write the test questions that I want you to be aware of them. So we're going to begin with Aphthous ulcers, canker sores, which are round ulcers on the oral mucosa. These are round or oval sort of lesions, ulcerations on the inside of the mouth. Usually they're on the cheeks, and they have an unknown etiology. I used to get these when I was a kid, maybe like 12, 13, 14, and they're just annoying, and there's nothing really to do about it. There's just these small open sores. They could be a little yellow, a little white, and they just sort of are what they are. The treatment, they're self-limiting. I used to do a half hydrogen peroxide solution. You could also do a chlorhexidine solution. You used to do it as a mouthwash, and you can do corticosteroids if it really bothers people. But That's sort of up to the individual. They're really benign. They go away on their own. Oral candidiasis is next, also known as thrush. This is a yeast infection of the mouth, right? So the interesting part here, and this is one that I like to use as a particular teaching point about the immune system, because the interesting thing here is 50% of humans have Candida in the oral cavity. So if you were to culture, 50% of people would be carrying this around. The difference is their immune systems fight it off. And part of what's hard to wrap your head around is your immune system's always at work. It's always battling. It's always fighting the outside environment to keep you intact and to keep the invaders out. Sometimes it does a good job of this, and sometimes it doesn't. Sometimes the enemy brings weapons that your immune system's not prepared for. Sometimes your immune system is run down and depleted for different reasons. And all of those factors go into how well you fight off diseases. That's why we talked a little bit about when the COVID epidemic was starting, making sure you were getting enough sleep, making sure you were getting the right nutrition, getting enough vitamin D. All those things will help you to improve your immune system. There's no way to measure overall immune system health, in particular from day to day, but there are things we know that will make your immune system stronger, better, and do a better job. There are things we know that will make it do a worse job. So as we go through, it looks like about half the people carry Candida in their mouths, right? That's just a very normal thing, just like all the bacteria that are constantly on your skin and you're fighting them off. Very, very normal. The difference is when your immune system is hampered in some way, that the yeast gets a foothold and then starts to grow a little bit more, then starts to grow a little bit more, and that's the problem. So risk factors include things that will affect your immune system. Newborns are probably the one thing that's not on the immune system list, but everything else sort of is. Uncontrolled diabetes, HIV or AIDS, chemotherapy. It's also a side effect of inhaled steroids. So I know my little guy, before soccer, he has to take an inhaled steroid. And what I always make him do is rinse his mouth out, because you don't want to wind up with a Candida infection in the back of your throat because you don't do that. It's a side effect of antibiotics, and dentures are poor hygiene. Clinical presentation. This white fluffy patches on the tongue or in the mouth. And you can get varying degrees of discomfort. So some people will have, it depends on how bad the infection is. If they're very, very painful eating or swallowing, or you just some red areas with some white patches. These lesions can be scraped off and may bleed. You get these punctate bleeding spots. On a KOH prep, you get pseudohyphae. Treatment. First and foremost, you want to address the underlying causes, those things that are creating the issue. In the case of my kid, if he wound up with oral thrush, it would be better hygiene with his inhaler. It wouldn't be that he's immunocompromised or any of those things, but you'd look for what's really causing this. What's the problem? What's affecting your immune system? So how you treat this, there's a couple different things you can do. Number one is going to be to use topical antifungals, so clotrimazole, miconazole, or nystatin. Nystatin seems to be the one that just comes up. The nystatin, swish and swallow, that just seems to be a very normal thing. Oral antifungals, you can also take fluconazole, about 100 milligrams 7 times a day. Not 7 times a day, set for 7 days will help. The next one is not on your blueprint, but I think it's valuable to know. And the reason why I say this is because we don't learn things in vacuums, right? One of the things that drives me nuts, and I think it makes it very hard for students to learn, is they memorize lists. So you take Candida, oral Candida, and you memorize all those facts I just read off about it, right? You try to hold them in your brain. But the world doesn't work in a vacuum. I think it's much easier to think of comparing things, because that's what you're going to see in your exam. That's what you're going to see in the office. So the question is going to be, when someone walks into the office, how do I diagnose this? Well, if they've got if they have a white patchy lesion in their mouth and they have HIV, then you've got all the pointers to oral Candida. You go to scrape it off, and it comes off, and it's got little punctate bleeding spots, and then you put it on the KOH prep, and now you see pseudohyphae. All of a sudden, you have a whole picture pointing you towards oral Candida, right? But again, that doesn't happen in a vacuum. You're trying to come up with a differential diagnosis. You're trying to come up with a diagnosis. Then you're trying to come up with a treatment. And everything kind of goes in an order. So in your differential diagnosis for oral Candida, it's going to be oral leukoplakia, because this is also a white patches found in the mouth. The difference here is these are going to be adherent, and they're associated with things like tobacco use, alcohol, smoking, and HPV. So it's a white oral plaque on the oral mucosa, usually found on a routine oral exam. You're going to want to biopsy this, and the treatment here is going to be to stop doing the thing that's creating it. So if you're chewing tobacco, you're going to want to have the patient stop doing that. And the issue here is you're going to want to monitor this closely because these are pre-malignant lesions. But I want you to understand that you're comparing things. So on your test, you're going to get a question that's going to talk about a white patch in someone's mouth. And you're going to get answer choices of oral leukoplakia or oral candidiasis will probably be B and C. And you're going to be frustrated because those are both white patches in someone's mouth. And then A and D will be things that don't matter at all, that aren't even close. But you're going to get two that are similar. And you're going to have to be able to separate them. And in this case, I would separate them by how they scrape off. And one is usually an immunocompromised situation. The other is caused by some sort of trauma in the sense of tobacco or alcohol, that kind of thing that affects the skin. Next, we have epiglottitis. This is an inflammation of the epiglottis, which is the little piece of tissue that prevents food from entering the trachea. And the important thing here is this may become life-threatening, secondary to swelling and inflammation of that epiglottis, and you can get obstruction of the trachea, which is obviously a very, very bad day. One of the interesting things here, and I don't know how this is going to affect your test, is historically this is a childhood disease, right? It's caused by, you get a bacterial infection with Haemophilus influenza, and kids come in with this. So that's how the descriptions usually are in the question stems. The difference is now that we have vaccinations, those numbers have dropped, and you actually see more of this in adults than you do in kids. So something to consider is just how they're going to present this on your test. And unfortunately, I can't give you that information, whether they do it from the historical perspective of being in a kid or an adult. They may do neither and just ask for how you treat it and that sort of thing, which makes it a lot easier. So they can also get a virus, which can cause this. On clinical presentation, people will have high fever, sore throat, difficulty moving air, difficulty swallowing. Drooling is a big one here. We'll talk about drooling later with the peritonsillar abscess, but those are really the two to think about when you see drooling. And with these, I've also always seen that the patient wants to be in a tripod position. So that's sitting down, leaning forward with your elbows on your knees and sort of with your back straight, and that lets more air move in through your trachea. So this is a position that these people tend to really like. Lab studies and physical exam findings. You can get stridor, which is a high-pitched breathing sound, which usually occurs with inspiration, but doesn't have to. Obviously, if they can't move air, they get cyanotic. And the best way to diagnose this is a direct visualization with laryngoscopy. The problem is you can cause spasms here, so you want to do this in the operating room and be prepared to intubate the patient. Throat cultures. And then another one is a C-spine film. You may see a thumbprint sign, which is one of those key terms that's associated with epiglottitis, the thumbprint sign on an x-ray. Now, again, people always come to me and say, hey, do you know that they don't do key terms anymore? And that makes me laugh like it just did, because of course they have to do key terms. There's no question about it. It's just how they do it. They want to hide them. They don't want to put them right out there. So you're never going to get a question that says, someone comes in and has a thumbprint sign on a C-spine. What's that mean? That's not going to happen. But the way I would use this is if I came across a question that had, a young kid who was drooling, who was leaning forward with his hands on his knee, with his elbows on his knees, having trouble moving air, and then they showed me a picture of an x-ray of his neck, I'd be thinking epiglottitis, because there is a x-ray finding for epiglottitis, right? There's no x-ray finding for pharyngitis. There's no x-ray finding for herpes, is what we're going to cover next. Under ENT, we only have so many things that are going to have an x-ray finding. So knowing that the thumbprint sign and what that looks like may be important, but knowing that there is an x-ray finding is really what matters, because they're going to put that x-ray up on the screen and you're going to be like, whoa, I don't even know what that means. I don't know how to look at it. I'm not sure those vertebrae look okay. So that's the part that you need to make the connection and not be looking for the term thumbprint sign, but understand that there's an x-ray finding on a C-spine film for epiglottitis, and you need to make that connection if they put up a film there. That's what I talk about. That's what I'm pushing for with key terms. It's not just memorizing lists and lists and lists. It's using them as a tool to understand how the questions are going to come and how to see the questions and them to present the answers to you. Treatments are going to be prepared for intubation. These patients can decompensate very quickly if they get an obstructed trachea, right? That's a very, very bad thing. Keep patient calm and breathing easily. When it comes down to breathing, right, that's our most important issue. And I joke around because for every sport that I coach, I'm obviously the go-to person for taking care of hurt children. So you get hit with a baseball, you get kicked in the shins in soccer, everybody looks at me. And the answer is 99% of the time, what I do for these children and why I get such great results with them so quickly is because I calm them down and get them to stop crying and to breathe. Because if you're crying, you're kind of hyperventilating and you're making things worse. So I take a little bit of time and calm them down and get them to breathe slowly and evenly. And miraculously, most of them make full recoveries very, very quickly. It's that panic that causes the problem. And here it's exactly the same thing. You want to keep the patient calm and breathing easily. Sometimes it's hard to do that with the parents there, but you do your best. Antibiotics may be necessary. If that's the case, it's going to be ceftriaxone is the one that they talk about here. I just got to adjust something in my notes, and I'm getting all kinds of texts now because, like I said, that email about the summer schedule just came out, and I don't know that there's a week anybody can go on vacation. So now the texts are flooding in with that. So we'll see. Who knows? All right. So herpes simplex, cold sores. Everybody has seen these before, knows a little bit about them. Herpes simplex virus type 1 and type 2 are the main culprits here. Since I've been in school, and even when I checked again now, it's pretty much they're trying to say that type 1 is oral herpes and type 2 is genital herpes, but there's a lot of overlap. This is transmitted through close contact with the person who's actively shedding the virus. The important thing here is you do not need to have an active, visible lesion to be shedding the virus. The other key to herpes is it's a lot like chickenpox and shingles. Once you've been infected, you never really get rid of the virus. It sort of hides out dormant in the nerve cells and then goes through these cycles of activation and dormant phases. And again, like we talked about before, the things that tend to trigger the reactivation is your immune system. I picture it as it's always fighting this virus, but it never completely eradicates it. It pushes it back, and the virus walls itself off and hides in the nerve cells, and it never quite gets killed. So then when your immune system drops its guard, the herpes virus climbs out of its hole and starts to win the fight again, until eventually the immune system comes back on board and starts to push the virus back into the nerve cells. And that goes on over and over and over and over. But you never really clear that virus. Just like with chickenpox, it comes back as shingles, right? Because that virus is dormant. The same cues for activation are very similar here with herpes. So you get things like a fever, which is maybe why we call them cold sores. Stress, either physical or mental, usually mental, will push you over the edge here and decrease your immune system enough that the herpes simplex virus can creep out. Immunosuppression, all those things. That's also one of the reasons why older people tend to get shingles more frequently. Your immune system's dropping down a little bit and losing that fight just a little bit. Doesn't take much for these viruses to reactivate. Clinical presentations here, the reoccurrences may be preceded by neurologic symptoms, so you get this burning and itching. And what these are in general, it's just a small group of painful vesicles, typically found along the vermilion border, so next to the corner of the mouth or in the genital area. These are cold, we know these as cold sores. And they're just that little teeny group of vesicles that comes out around the mouth, especially when you're under a lot of stress. All right, so there's a couple other things with herpes. I'm not going to go too deep into them here, but just so that you're aware, herpetic whitlow is the infection of the same infection in the fingers. Herpetic keratitis, same idea in the eye. Herpes encephalitis is when it gets into the CNS, neonatal infection. So if a female patient has an active herpes infection, in the genital area, that's an indication for a C-section. Again, not necessarily something you need to know for this section, but I think just good touch points as we go through. Labs and studies, this is generally a clinical diagnosis. Most people can pick this out. Stains of those vesicles will show multinucleated giant cells. Multinucleated giant cells may be something you want to jot down. And that's what I'm doing in my notes right now, because that also seems to make a good question. All right. Antibody test is available. Treatment, well, like we said, there's no real cure. Typically, it's self-limiting. You can use topical antivirals like 5% acyclovir, some sort of a cream you can put on there. You can also use oral antivirals, which tend to work pretty well but are expensive. And then lastly, you can use Tylenol and ibuprofen. Again, this is painful. These hurt. This is not insignificant for the people going through it. All right, next we have laryngitis, which is an inflammation of the larynx or the vocal cords. Causes here is usually an infection like an upper respiratory thing like a rhinovirus, adenovirus, that sort of thing. You can also end up with the bacterial infections like a group A strep in this case. And then more commonly, probably, there are non-infectious causes, or maybe just as commonly, like overuse. That's going to be for people like singers or speakers. You're going to have acid reflux can cause this. And as a result of allergies, you can get this. And then things like trauma, including smoking. Clinical presentation, the most obvious one is being hoarse, that hoarse voice where you're just kind of squeaky. You can get a fever, swollen glands, cough, cold and flu symptoms. All depends on the causative agent, right? If it's acid reflux or overuse, you're not going to get a fever. That's not going to happen. You need to think that through a little bit. Lab studies and physical exam findings is usually a clinical diagnosis. Laryngoscopy may be helpful, but really that's withheld for just chronic issues. Treatment is going to be resting the voice, humidify the air. Fluids is always good. Treat for GERD if that's appropriate, and antibiotics again if appropriate. We've got two more left before wrapping up for today. The next one is acute pharyngitis. This is the most, probably the most common thing we hear about, which is a sore throat, right? The problem with the sore throat isn't that it's hard to diagnose. The problem with the sore throat is what causes it, what do people think's going on, and then how do you treat it? So most commonly you have viral infections, which is things like Epstein-Barr, mono, herpes, cold viruses like adenovirus or rhinovirus or RSV can cause this. CMV can cause this. All kinds of stuff can. You can get a bacterial infection, which is the one that we hear the most about, right? This is your strep pneumonia infection. That accounts for about 15 to 30% of these cases. So it's a real thing. And it happens a lot. But every time somebody comes in with a scratchy throat doesn't mean they have strep throat. Every time someone comes in with a red throat doesn't mean they have strep throat. So it's balancing those treatment plans, right? And what you want to do for these people. Same thing on your exam. So how do you tell them apart? So we've got Neisseria, Mycoplasma, and Chlamydia, or a couple other bacteria that can cause this problem. And again, so the clinical presentation here is going to be a little bit determined by what the causative agent is, right? So it's not going to be the same for everything, although it'll be similar. So sudden onset, fever and chills are very possible, difficulty swallowing, tender swollen throat. The no cough thing sort of points toward a strep B, but doesn't define it by any means. Typically younger than 15 years old for a group B strep. Lab studies and physical exam findings. So here's one place you can kind of separate things out a little bit. Tender anterior cervical adenopathy for group B strep. And you can get tender posterior cervical adenopathy for mononucleosis, although that can also be generalized. So those kind of help, maybe in a test question. You can get purulent exudate in the pharynx, shaggy white tonsillar exudate if you should be thinking about mono. And the throat cultures and the rapid antigen tests for strep are fairly accurate, 90 to 95%, 90 to 99%, depending on how those work. Treatment. So symptomatic treatment is going to be the mainstay. NSAIDs, Tylenol, fluids, always good for those. Appropriate antibiotic treatment. So if you have a strep and you want to treat that, penicillin twice a day or amoxicillin 3 times a day are the way to go currently. Lastly, for today, we have peritonsillar abscess. This is an abscess near the tonsils, right? It's not that complicated. Most commonly secondary to tonsillitis, think pharyngitis. Clinical presentation, severe one-sided sore throat. I love that part because it makes a lot of sense in my head and I see how that separates it out from other throat issues, right? Or other oral issues. If I have a one-sided pain in my throat, I'm going to think of a mass of an abscess, right? Which is just a walled off mass of bacteria. And that makes a lot more sense than the generalized picture, which could be a lot of different things. But that one-sided severe sore throat just creates a really nice picture in my head for peritonsillar abscess. They can get difficulty swallowing and drooling here as well. And the hot potato voice, that's that muffled, voice as if they're holding a very hot potato in their mouth. It doesn't make any sense to me. I don't get that one bit. I just think of it as like a very muffled voice. The person has trouble speaking. You can YouTube those videos. People have recorded themselves with it. I hear a difference in their voice. I'm not sure how well I would do picking it out, but that muffled hot potato voice, you definitely want to attach that to peritonsillar abscess in your mind. They're going to get a fever with this, tender glands, and difficulty opening their mouths. The labs and studies, obviously they have a erythematous pharynx. The uvula is displaced towards the unaffected side. Right? So if you have a growth on one side, it's going to push it over. Just sort of makes sense. Ultrasounds and CAT scans may be helpful here. Treatment, these are the kinds of things I want you to stop and think a little bit about, because I want to memorize as few lists as possible when I'm studying. I don't want to spend and actually this may be our good study tip for today before we hit the treatments here. And something we've been talking about throughout this section is not to spend all of your time in just memorization. People talk about understanding versus memorizing. And I think understanding is part of it, but it's just thinking is maybe a bigger part of it. Using your brain, using that what got you here isn't just the ability to memorize lists, right? So treatment for a peritonsillar abscess. So if you have a mass in your neck that's filled with an invading organism, how are you going to treat that? What would you do? Think about it just for a minute. Spend a little bit of time. Don't just have someone tell you what to do. Think about how you would do this. What would be something you would try? Well, you try antibiotics, right? Antibiotics don't tend to penetrate into abscesses very well. Clindamycin is a good choice, and you're going to use it, but that alone may not be enough. So what do you do next? What if an antibiotic is ineffective and you know you have a peritonsillar abscess? Well, you're going to have to drain it somehow. You have to get pus under pressure is what's really painful. And in addition to that, you've got to get in and clean that thing out, or the antibiotic's not going to get in there. So you've got to do an incision and drainage, or a needle aspiration is a good place to start. A tonsillectomy may also be something you're going to add to your list, but it doesn't have to be. But you don't need to memorize treatments for peritonsillar abscess. Maybe Clinda as the specific antibiotic. But if you stop and think, you're going to do something to get the pus out. So you're going to go in there with a needle or a knife, and then you're going to use antibiotics. You don't have to memorize this list, and that takes some cognitive load off from memorizing lots of things. And I think you can do that if you create these pictures in your mind and think through what a real world situation would be like instead of just memorizing lists on paper. So that's going to be actually, I'm just going to leave that. I had something else planned for today that maybe I'll push off to 2 weeks from now when I do the next show, but let's do that for today. The idea that it isn't just understanding instead of memorizing, it's knowing the lists, but instead of memorizing them, put them into these compartments that you can use. Picture how someone would have come up with the treatment. What would you have done if you didn't know what to do? If no one told you what to do, what would you do? And if you think that through a handful of times, it's surprising how much more it'll stick in your brain if you've thought it through than if you just try to memorize a list. Memorizing lists is very, very difficult. The human brain was not designed to memorize lists. It was designed to see pictures and understand stories. So if you can create those images, if you can create that thought of what would I do in this situation? So I've got a kid with a sore throat who comes into the office. Well, what would I do? What am I looking for? I'm going to look in his throat. And if it's red, that's going to push me towards a pharyngitis. But now I've got to figure out what type of pharyngitis. So what's going to give me some clues to tell me what type? Well, obviously the antigen, the cultures and antigen tests are going to be helpful. But what else can I do? Does he have a cough? Does he have swollen nodes? Has he had a fever? Things like that. How am I going to tell the difference? And you need to think through those and do these little mental experiments. A patient comes in with a white oral patch in his mouth. We talked about this at the beginning. How would you handle that situation? They're sitting in front of you. It's a 65-year-old guy, and you're doing a routine exam, and you come across a patch of a white patch lesion on the inside of his buccal mucosa. What do you do next? Don't memorize the list. What would you do? Would you poke at it? I think that makes sense, right? Most of us would probably poke at it. If it comes off and starts to bleed, you're thinking maybe it's oral candida. If it's hard and attached and it doesn't, and you talk to the patient and it turns out that he's a smoker and he drinks a 6-pack every night and he chews tobacco, then you're starting to think maybe it's oral leukoplakia. And how would you treat that? So go through some of those little bits of stories, that little bit of a clinical setting. And like I said, it's not necessarily understanding is important. And I don't mean to, I'm not sure how to separate that out more clearly for you. It is understanding, but it's more thinking through how you would handle a situation, what could be done, and not just memorizing the lists over and over. So that's our study tip for today. We're just going to use that and not go into a separate one. Our study tip for today is understand what you're doing, but think it through. Think through the treatments. Think through how you would attack it in the office. All right, so let's get to our priming questions and answer those for you. Pseudo HIV on KOH prep should make you think of what diagnosis? We did this right at the beginning. It was Candida. Name the white oral lesion that is easily scraped off but bleeds when removed. Again, we just did this a couple times. Oral candidiasis. Hopefully you nailed that one. When hearing the term hot potato voice, what diagnosis should you be thinking of? Peritonsillar abscess. Excellent. So that takes us out for today. Absolutely fantastic. Again, if you head over to iTunes, we are narrowing in on 1,000 iTunes reviews. I would totally love it to cross that mark. I'd really, really appreciate you guys heading over there and checking that out and leaving a fantastic review for how wonderful the show is and how helpful it's been for you. That would just be great. Anyway, take care. Good luck on your exams this week, and I'd love to hear how you do either way, up or down. Let me know, and we'll go through it. Take care. Good luck.